Director for Behavioral Health Services for the County of San Diego in California. And Alisha, go ahead and introduce yourself.
Hi, I'm Alisha Eftekhari, Assistant Medical Services Administrator with Behavioral Health Services.
Thank you. We're happy to present to you. We have some learning objectives, Alisha.
We do. So today we're going to talk about the strategic planning that was involved as part of the implementation process for the Mobile Crisis Response Team in San Diego. We will talk about how we went from 2 teams to 44 teams, and we're going to also talk about data and the key partnerships that helped us get to where we are today. And lastly, we'll share a little bit about how diversity, equity, and inclusion is incorporated throughout the process. Next slide, Piedad.
Thank you. So a bit of a background for you. San Diego County has about 3.2 million individuals in our community. We're a very large and diverse county. In comparison, LA County is about 10, 11 million individuals. Orange County is pretty much similar to us in size. And wanted to just talk to you about why we started the Mobile Crisis Response Team, also known as MCRT. We certainly noted that there was a need for this service as we wanted to address non-law enforcement response to our community with behavioral health crisis. So the MCRT is a non-law enforcement team that responds to all members of the community, including children, youth, adults, and older adults. The teams are composed of a licensed clinician, a peer support specialist, meaning a person with lived experience, and a case manager. The teams provide clinical assessments in person in the community. They conduct de-escalation and connect individuals with the appropriate level of behavioral health services to include not only mental health, but also substance use services. This program is 24/7, Monday through Sunday. And we also are able, through our licensed mental health clinicians, to conduct 5150s. So how do we access, next please, sorry. How do we access the Mobile Crisis Response Team? How does a community member access the MCRT? And we launched in 2021. We just had an anniversary. We opened with just 2 teams, and we are now at 44 teams. This is, as I mentioned, is an alternative response to law enforcement response in the community where there are crises with behavioral health symptom. We actually have different methods to access the MCRT, but we're going to talk with you as to our primary area. The community members access the MCRT through the Access and Crisis Line, which is 24/7 telephonic service. It operates with licensed mental health clinicians, and they do a triage or a screening for the most appropriate services, to include routine care, to include emergency services, whether it's emergency medical services or the MCR team, or if they need to connect with 911 for a response. Here you can see that the dispatcher at the Access and Crisis Line will do the screening, as I mentioned, and then dispatch the appropriate service according to the client need. The dispatchers at the Access and Crisis Line are trained on ensuring that the MCRT response is clear for safety. There's a very specific criteria that we utilize, and Alisha is going to talk with you about that. Next, please.
So the eligibility criteria that Piedad mentioned was created through very close partnership over the span of a year and a half to develop these criteria that are used not only by the 11 law enforcement jurisdictions that are part of that MOA, but also used by other direct referral access points, such as the Access and Crisis Line. And this allows us to ensure the same consistent type of referrals are coming through that allow for the safety of the mobile crisis response team members. It's also important for the safety of the community members to make sure that we are getting them the right type of emergency response. So these are the criteria that were developed. The primary criteria include no injuries requiring medical attention, so EMS is not needed. No weapons are being used or flashed, wielded, or involved, and no imminent threat of danger or violence to themselves or to others. And next, we are going to show you all a quick video that we think does a nice job outlining the services for you. And you can also find this video on our webpage, and we'll have the link for that on our last slide.
Welcome to the Mobile Crisis Response Team. We would like to provide you with an overview of the services we provide and how to access them. Our main goal is to break the cycle of a person's mental health struggles. MCRT brings rapid crisis support to people experiencing mental health or substance use crises in the community. The focus of our engagement is to help people to get the support they need by responding with a team of behavioral health clinicians who can stabilize and link individuals to behavioral health services as needed. MCRT provides non-crisis intervention to all ages throughout San Diego County. Each team includes a licensed clinician, one master's level case manager, and a peer support specialist. The team responds by providing evaluation, crisis intervention, and care coordination.
MCRT se esfuerza para derribar barreras a los servicios de salud mental y uso de sustancias en San Diego. Nosotros tenemos miembros de los equipos móviles que hablan varios idiomas. También tenemos un servicio que ayuda a traducir para clientes en la comunidad. Lo más importante de nuestros servicios es que son accesibles para gente de cualquier comunidad. Tenemos personal bilingüe en cada turno y acceso a una línea de idiomas las 24 horas del día, los 7 días de la semana para satisfacer las necesidades de cualquier idioma que se utiliza en la comunidad.
MCRT has a call center staffed 24/7 by clinicians trained to screen and identify the best response. The MCRT call center takes calls from both 911 and the Accident Crisis Line. Currently, the public cannot call directly to MCRT. In order to receive services from MCRT, there needs to be an identified mental health or substance use crisis that needs support from a specialized team. As the safety of our team and the community is paramount, we need to be clear of certain safety criteria, including no weapons on scene, no threat of immediate danger to themselves or someone else, and no physical injuries requiring a medical response. Here are some examples of calls we have taken that have had a lot of success. Threatening suicide, but no immediate risk to harm self, severely depressed, for example, hopeless, sad, not eating, not getting out of bed, symptoms of psychosis such as someone paranoid, yelling at unseen others, delusions, and or hearing voices. If criteria is met and we have a team available, we will dispatch out a mobile team and we will provide an estimated time of arrival.
Once the dispatcher accepts the call for MCRT, our team will deploy where the individual is located in the community. We will do a further evaluation to determine any safety concern, what the behavioral health need is, and what the best interventions are for the current situation. Our primary goal is to assess, stabilize the individual, and connect them to services in the community for ongoing care. Teams respond in vehicles equipped with safety features to support the 5150s and a host of other resources and supplies to assist those being served.
We partner with crisis stabilization units, hospitals, outpatient mental health programs, substance use programs, and other community programs to best serve our clients and connect them to ongoing services. Following our initial intervention, individuals who are not connected with behavioral health services can expect our teams to provide short-term care coordination for up to 30 days. Not all calls are home runs, but some are singles and those are still successes.
Here at MCRT, we are systematically bridging the gap in behavioral health services and the justice system through collaborative efforts. MCRT meets each week with all 11 law enforcement jurisdictions to talk about what's not working and what we can improve on to help support our community. We are also working with existing behavioral health providers in the community to support the continuum of care. If you or someone you know is struggling with a behavioral health or a substance use crisis, please do not hesitate to call the Access and Crisis line at 888-724-7240, and they will connect you with MCRT or the appropriate service to meet your needs.
Thank you. Next. Yes, thank you. What we wanted to just emphasize with the implementation of MCRT, based on the eligibility criteria that Alisha mentioned, that criteria is performed by all the different services that you see here in your slide, the Access and Crisis Line or 988, law enforcement, and the public school districts K-12 that we just initiated. So how do you connect MCRT? How does the community connect with MCRT? Through the Access and Crisis Line, tribal communities, we have approximately 18 here in San Diego, colleges and universities, that's another 30 plus colleges and university, as well as community members, as mentioned, and our treatment providers in the community. Law enforcement also utilizes the eligibility criteria through our 911 system, and also the dispatch. I guess it's another way of calling this, and also the field officers utilize this criteria, as well as our emergency psychiatric response team, which is an officer and a clinician, the PERT team. With the colleges and universities that we already implemented MCRT, campus police, military police. We have a large military presence here in San Diego, and most recently the FBI as well. For K-12, we started in November of 2024. It's a phased approach, a rollout approach with the school districts and the universities and colleges. We have a very specific training for K-12. We've done about 5 or 6 webinars with San Diego County Office of Ed as the lead. And certainly we work with them and the providers on campus, whether it's the teachers or the VPs, school vice presidents, and also the school resource officers, the SROs. We're gonna talk next, Alisha, with very specific key lessons, if you will, that we have learned through our 4-year implementation, and it's a never-ending process. So, Alisha?
Yeah, so just to summarize some of the key lessons we've learned so far is to start small and scale smart. So what I mean by that is make sure that you all are using your data. We like to do a lot of pilots. So we piloted, you could say, with 2 teams. We started with only 2 teams, and before strategically graduating to up to 44 teams, we looked at the data and we looked at the call volume, the number of calls that MCRT was receiving, at the times that the calls were coming in, at the number of behavioral health calls our access and crisis line was receiving, at the number of behavioral health calls law enforcement was receiving. And we use that data to inform the growth. Another example of how we use the data is we look at where the calls are coming in, and the programs will strategically station and locate their vehicles in the community based on where the calls are coming in and the volume of the calls. That really helps ensure that we are providing a timely response, responding in under an hour. Another key lesson is to partner early and often in the process. Receiving that early buy-in and support from key partners, such as law enforcement, behavioral health partners, community organizations, has really been essential to the success of our MCRT and the growth. And when we do those partnerships, we've learned that it's really important to have clear communication, clear and frequent, ongoing, open lines of communication, and to be clear on what the different roles and expectations are, and the shared goal, making sure that we always come together around the shared goal, which is the well-being of our community members and students, is critical and brings us back to a strong point of collaboration. Raising awareness intentionally. So what I mean by this is making sure, looking at the data and being strategic about the messaging that you are putting out there about your mobile crisis response team. We launched a campaign a couple years back to help increase awareness, reduce stigma around using MCRT services. And we also use the data to help inform the media, to help inform that media campaign and another one we're currently working on, but to help inform how the campaign will look. We have flyers on our website in different threshold languages, and we have our video on our county website. We keep an FAQ and an email address so the community can ask questions, and we continue to not just educate but re-educate the community. It's not one and done. It has to be consistent and ongoing, because we've learned that there's a lot of turnover in different programs and organizations, and out of sight, out of mind. So it's important to be present and to be consistent, and consistency is what is going to build the trust. And so you have to continue to show up and remember that relationships take time and they take work. So it's ongoing, it's continuous, and it's important to be a good partner. You have to listen and adapt, and that means being flexible. And as our model has evolved, Piedad mentioned, our model has come a long way. It's evolved, and we anticipate that it will continue to evolve because the community evolves, the needs of the community evolve. So for us to be good stewards, we need to continue to look at the data, listen to the community, listen to our partners, and evolve with the needs. Next slide, please. Okay, data. So the data has really been foundational and very important to the success and growth and credibility of our MCRT. And some of the ways that the data has been used to inform the growth and the need for additional teams is by looking at the data and tracking when there's not a team available because of call volume, and the response time. So those are two key metrics that we've used to help inform us of the growth that's needed. And also, I mentioned earlier how we use it in real-time operations for staging teams, for example, in the community. but also for being able to inform community members or law enforcement partners or schools when they call by using data to help inform us and the beacon system that the programs use. We can give an estimate on the response time, and we have the average. We track the average response time, and we can inform the community of that data point. And that data point's been really helpful to be able to share with our partners. Transparency is really important with our data. So we use our data to inform our key stakeholder partners, such as law enforcement, on the number of referrals that are coming through, our average response time, different information. It's important to build transparency has helped build the relationship. Also, we get a lot of inquiries from elected officials, from media, from community advocates, you name it, we get it. The community members, they want to know, what is the data telling us? How do we know MCRT works? How can we trust that MCRT is gonna help us in our time of need? So it's important for us to have the data points available to be able to respond to these questions and not just assume that we know the answers on what's going to help improve, but to be able to share the data with our partners and it's a shared response. How can we improve together the program and services? So we have to continue to ask and listen to the community on the data. The data helps hold us accountable and really has been a roadmap for how MCRT has evolved. The data builds trust, being able to share the data points. I remember when we first started with law enforcement, they were hesitant to send us the calls. They were not sure that a non-law enforcement team, clinician-led team, was going to be able to handle the types of calls that we were asking them to send us. So we tracked the data. They slowly built the trust and started to send us the calls, and we tracked every call that came in and how often law enforcement was needed. And the data showed us that less than 2% of the calls, all the calls that MCRT responded to, required a law enforcement intervention. And they loved that data point, and they have told us that you all need to continue to share this data point with all the law enforcement partners, because that's going to help them buy in and help them trust and send the referrals. So data, we can't highlight enough the importance of data. Next, Piedad.
Thank you. So following up on additional data that we collected on our call volume. And why is this important? Because we need to know how many individuals are accessing MCRT, how many of those we responded to, and how many of those had an intervention. So you have two in this bar graph. Fiscal year 23-24, you have approximately 7,532 total calls. And then the orange bar really addresses the calls that were accepted by MCRT. They went out to the community and they accepted the call. And once they got to where the individual was, that either the call was canceled or the calls were, the intervention was declined by the individual, or the individual could not be located in the community, because we also respond to homeless individuals in crisis, right? In 24-25, you can see that it's 9th month review, July through February. And we are almost exceeded. No, actually, the total volume for those 9 months is exceeded from the last fiscal year to 7,634. So this demonstrates that we're growing, that the community is much more aware of us, that we are doing additional responses to the community. Next slide, please. Here's another tracking data point that we do, disposition of interventions. And usually our goal and our contractor expectations, we mentioned Telecare and Exios are the two contractors based on the video that you all saw. We have very specific goals, and certainly that is one of them, is to be able to respond, right, within under an hour, right? And one of the key things that we have here in the bar graph is that about 59% or so of the responses in the community are clients stabilized in the field, right? And that no other services are needed. About 30% of those individuals were taken to lower levels of care, such as a crisis stabilization unit. And really what has worked here in San Diego is the pairing of MCRT and crisis stabilization units, which we have 6 of them around the county, 1 specifically for children and youth under 18. And so we also average about, I would say, 12% of our intervention is to a higher level of care, including emergency departments. And they also not only to address medical issues or to address the psychiatric needs, and usually it's for acute care hospitalization. And Alisha mentioned that about 2% required law enforcement intervention. Next, please. So here's what we have for our contractors. Our contractors have a statement of work, and here are the primary goals. 80% of interventions are diverted from higher levels of care. You have Telecare and you have Exodus as one comparison. We also, I mentioned that we respond under, we have to respond per state requirements under an hour, and about 80% of all calls meet this under an hour requirement. And all of the 100% of the clients that we come in contact with receive a follow-up call within 3 days to ensure that the client has connected to behavioral health services, whether it's a mental health or a substance use situation. There are times that they do not connect, and certainly we're tracking those unconnected clients to determine the reasons as to why they are not connecting to the referral source that we made. Both programs are reporting and meeting the goals of their statement of work, and we're very happy about that. I think that we also have a client satisfaction survey that we do for clients that receive these services. So we're analyzing that data, and overall their satisfaction exceeds 90%. Next, please. Here is the client satisfaction survey results. It includes if services were culturally relevant. You see year 1, 23, 24, and then you see the increase in the orange bar graph as well for 24, 25. We also address resources to connect the client not only with mental health or substance use resources, but whatever else they need around housing or registering or enrolling in Medicaid, Medi-Cal here in San Diego. And we also, survey staff communication and staff demeanor to ensure that clients are receiving what the services they need, but also what is the attitude and the tone and the intervention from a staff perspective. Next. So how do we integrate diversity, equity, and inclusion in our service line in MCRT? Certainly, a major point is ensuring the connection to behavioral health services in a culturally responsive approach. We have a diverse community in San Diego. About 33% of the community is of Latino descent. We also have approximately 6% African American, a little bit higher, about 9% of Asian Pacific Islander. So our services have to be culturally responsive. How do they do that? These contractors, certainly by hiring, recruitment and hiring of representation in their staff from the community. So our MCRT have language staff that speak various languages. They also, if they don't have the particular language of the individual, we can connect them just in time while the intervention is being done for interpreter services. We also require these contractors to provide to the county cultural competence plan and document the cultural competence training, which is a minimum of 4 hours per year. We also have a skill-based training that is over 20 hours for a 6-month period. But that cultural responsive training is skill-based, and we contract for that services. So all providers in the system of care can participate in that skill-based training. In our contracts, we also have the expectation that our services are going to be trauma-informed care. They have to be a client-centered approach. Our approach is recovery rehabilitation with a biopsychosocial approach that is client-centered. And with the diverse communities, the responses, the MCRT response is tailored for special populations, particularly the linguistic approach. And also the nuances of different cultures need to be integrated in the response. Alisha, next, please.
Okay, so we have looked at the data. We used Pop Health, our population health data, and we looked at the different age groups and race and ethnicities that MCRT has responded to help identify the gaps, to help us understand the unmet needs and where we need to focus some of our efforts on. So the data has shown us that certain age groups, such for us, it's those who are 70 and over and 15 and under, and the race and ethnicity group has been Asian Pacific Islanders, where we have some work to do and could increase our MCRT response. Some of the ways that we've done that and are taking action to do this is through our campaign, our targeted messaging, and being strategic about where we're placing the billboards and the languages that we're using and the type of media. And then also community engagement, targeted community engagement towards these groups. Next slide, please.
Thank you. So I mentioned previously that MCRT has been a phased approach, a scaled approach, and we continue to reevaluate what's needed. And certainly we know that future expansion includes fire EMS, emergency medical services. Right now, we are not call responding, or they're not transferring referrals, behavioral health crisis to us when they're in the community. They're responding to the community rather. And that has to do with a lot of the regulations that fire EMS has. And so we're working through that, piloting with one of the stations in the North County and see where that takes us as a pilot. We also need to expand to private schools. Right now we're doing responding to K-12 public schools. We have quite a bit of number of private schools that we would also like to ensure that we can respond to them. Additionally, colleges and universities, we have 30 plus, so we have less than 10 colleges and universities participating right now. And as Alisha mentioned, it takes a lot of collaboration and partnering and logistics to introduce the MCRT to any of these expansion efforts. 18 tribal communities, we are working with 2 communities, tribal communities here in San Diego, and again, re-emphasizing the collaboration and the partnership and the development of trust with the tribal communities and their leadership to be able to respond to these communities. Lastly, one of the things that we have been able to do, and we just contracted with UCSD, University of California, San Diego, for independent evaluation of the mobile crisis response team. So I'm very excited about this evaluation. It will also include a financial evaluation in terms of cost effectiveness of the mobile crisis response team, and that would certainly include the lowering of utilization of acute care services and emergency departments and so on. So I'm excited about that. Lastly, I want to provide for you, next please, the contact information for myself and also for Alisha. We have had the opportunity to get requests for tours of the MCRT program and the crisis stabilizations from the state of California, different counties. Other states have been here to San Diego for a visit and a tour, and also actually internationally, the Netherlands, the Justice Department was here months back around the implementation of these 2 services, which is something that they wanted to do in the Netherlands. So with that, we'll close with Q&A. Thank you very much for your attention.